Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm your guide for this journey, Dr. Lynn-Marie Morsky, and today we're going to be discussing psilocybin for obsessive-compulsive disorder with Sorcha O'Connor. Sorcha is completing her neuroscience PhD at Imperial College London, specializing in mental health research. She led PsilOCD, a pioneering study investigating low-dose psilocybin as a treatment for both the clinical symptoms and cognitive features of obsessive-compulsive disorder. Now, before we get to Sorcha, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And a last reminder, if you are a clinician and you'd like to learn more about psychedelics for conditions like OCD and many others, please take a look at the Psychedelic Medicine Association. We are dedicated to getting clinicians comfortable discussing psychedelics with their patients, learning about the indications and what's legal when, and the contraindications and all of those things so that when a patient comes asking about psychedelics, you feel confident to have those discussions and perhaps refer patients when appropriate. To find out more, please check out psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us today, Sorcha.
Thanks for having me. It's great to be on to talk about this topic.
I'm very excited for this. We have not talked about OCD once in the 5 years of that we've been doing this show. And so if we could start by having you talk to us a little bit about obsessive compulsive disorder, or OCD. Can you talk a little bit about how it presents?
Sure. So we can consider OCD an anxiety-based condition that can be summarized as an intolerance of uncertainty around one or more themes. So people tend to think of the stereotypical depiction of OCD being contamination OCD or someone with an affinity for order and symmetry. But really, OCD can latch on to virtually any theme under the sun, with people dealing with fears around identity, around responsibility for others, their own health, and many other possible topics. And we can split OCD into two different facets, into obsessions and compulsions. The former describes the unwanted thoughts that the individual deals with, and then the compulsions are any effort that they go to, whether mentally or physically, to either decrease their anxiety in the moment and or prevent their feared outcomes from transpiring. So people end up in quite a rigid cycle where they fear specific outcomes related to a topic, whether something like, catching something serious, a data leak, something about their identity, something going wrong when they look after others, like their own children. And then they end up ritualizing, whether mentally or physically or both, in order to try and avoid these outcomes. And this ends up being a vicious cycle because by performing these safety behaviors, the brain receives feedback because effectively the brain's just, in your skull, and it's got to receive input from both the outside world and your own interpretations of what's going on. So this puts the person in a position where they become even more sure that their fears are true and valid to hold on to. So it really is a catch-22 pattern once it develops, unless people get treated effectively. And traditionally, OCD has been viewed as a very anxiety-focused condition with anxiety at the crux of the pattern. And this is because anxiety spectrum conditions are very common comorbidities. We see high comorbidity rates for panic disorder, specific phobias, conditions like agoraphobia, generalized anxiety disorder, and even PTSD. And we can also see this in the neurobiology of OCD and anxiety spectrum conditions. There's a significant overlap in some of the brain loci involved, although OCD does have one very large brain circuit that is mainly associated with a symptomatology called the corticostriatal or thalamocortical loop. And this does differentiate it from other anxiety conditions that don't tend to involve abnormalities in that whole loop. But yeah, anyhow, we can say that anxiety is definitely at the crux of the pattern. But recently, there's been a shift towards viewing OCD as more of a manifestation of compulsivity, with anxiety definitely at the crux of it, but not necessarily a causal driver. And this shift is reflected in the DSM-5 reclassification of OCD as an OCRD, which, as you probably have said the acronym first, Obsessive-Compulsive Related Disorder category. And this category also contains conditions like hoarding, like body dysmorphic disorder, so other conditions that involve trait compulsivity and rituals that people get themselves locked into. And this is all relevant because it's inspired research into the cognitive features of OCD. And this all goes beyond just the mood-based, anxiety-based symptoms. So we now know that people with OCD have deficits in cognitive flexibility, and this can be measured in a specific task called the attentional set shifting task. There's a specific computerized version that people tend to use called the intradimensional, extra-dimensional set shift. And it sounds very complex, but in short, it basically assesses your ability to learn a generalized rule in one perceptual dimension, such as color, and then shift to another dimension, such as shape or size. And people with OCD are good at learning the rules, but they struggle to disengage from one perceptual dimension and shift to the other. So we see this deficit in people with OCD, and it's even seen in unaffected relatives, which has led researchers to view it as an endophenotype or trait that might actually precede symptoms in sufferers. And there's also another area of cognition that's really important to talk about in the context of OCD, which is metacognition, and that's our ability to reflect on our own thinking processes and our own strategies in life. And metacognition allows us to assess our confidence, so it lets us engage in a task and think, are we proficient? Like, are we doing well in this? Is it a good idea to double down on this strategy? But sometimes confidence and performance can become dissociated, such that we can be overconfident when we're not great at something, or we can be underconfident. And people with OCD tend towards being underconfident in domains that go beyond their specific fears. So we can see intuitively that they're probably going to be underconfident in, if their OCD centers around contamination, they probably will have some negative beliefs and a tendency to doubt their own health and maybe the capability of others to help them if something went wrong. But we can also see in general tasks that when people have to, perform a perceptual discrimination task, they tend to rate their answers with lower confidence compared to healthy controls or just people without OCD. And this is all very relevant because it suggests that OCD is a very complex behavioral pattern that isn't just an anxiety disorder that we can just quell by suppressing anxiety or something like that in patients. It's definitely a constellation of cognitive features and anxiety-driven behaviors.
Well, thank you for that thorough description. I just learned so much in 3.5 minutes. Can you remind me? You said it was OCRD. Is that what the new name is?
Yeah, exactly. Obsessive-compulsive related disorders is where OCD sits now in the DSM-5.
Okay. And because I had just recently learned that there is OCD and then there is obsessive compulsive personality disorder. And then there are also obsessive compulsive personality traits. Those are all like 3 different things, correct?
Yeah, exactly. OCPD is slightly different. Being a personality disorder, it describes more perfectionism and rigidness as personality traits. And people can definitely have both. And I'd say most people with OCPD have OCD traits. But OCPD, as far as I know, is more about someone's attitude towards life and how they engage with other people rather than having, a specific phobic pattern.
That makes sense.
But again, there's probably, a very strong genetic overlap.
Very interesting. And how is OCD currently treated and how effective are these interventions?
Currently, the gold standard treatment for OCD is a type of therapy called exposure response prevention, or ERP. And this basically exposes patients to their worst fears in an incremental, systematic way. And classically, this was done in quite a rudimentary way where people would be flooded with, exposure to, if they feared, again, contamination being a good example because it was, one of the earliest recognized manifestations of OCD. People would be, forced to, use a dirty toothbrush or do something grim like that. And scientists thought that, the brain lets go of fears when it receives enough evidence that thing doesn't need to be feared. So there was definitely a solid basis for doing that type of flooding exposure. But nowadays it's done in a slightly more sophisticated way. It's viewed through more of an active learning model, and people realize it's more about testing specific hypotheses that people fear within that theme rather than just exposing them to highly anxiety-inducing content. So it will be done. People do imaginal exposures now as well, where they'll imagine letting go of control. And crucially, this is the main part of ERP. People don't perform their compulsions. So they're exposing themselves without doing any of the safety behaviors, whether mentally or physically, that they would have done before.
Interesting. And then in that, like say that the trigger happens and they can't do the compulsive behavior. Obviously that leaves them, I would assume, leaves them in a pretty anxious state.
Yeah,
Is the therapy to try to wind down that anxiety without the compulsive behavior?
yeah, exactly. So the goal of ERP is to desensitize the brain so that people can, hear maybe, someone talking about that topic and not be triggered, or if they fear, control over maybe data, they can go back to their job and not be worried about data leaks. The goal is to just show the brain that nothing to do with the theme, whether that be the person's thoughts about the theme or actual exposure to it, is dangerous. And gradually the anxiety does decrease for people, but there's a very high perceived barrier of entry. As you pointed out, it is a very anxiogenic experience for people typically, even when it's done in a slightly more refined way. So that's why some people do need pharmacotherapy for OCD, medication, and the most common type given are selective serotonin reuptake inhibitors, or SSRIs, that are also given for depression, but they're typically given at higher doses in OCD. And these produce moderate benefits for around 40 to 60% of people. They're by no means a silver bullet, but they can support people by just decreasing that that anxiety, and also improving people's lowered mood sometimes and helping them get through the initial stages of therapy. Sometimes people stay on them for prolonged periods of time, but lots of people dislike the side effects, and some people are just treatment resistant as well. And then they can try adjunctive pharmacotherapy, like giving antipsychotics off-label, or even mood stabilizers like lamotrigine, effectively just trying to tap into different neurotransmitter systems to recalibrate the brain a bit. But to be honest, OCD is I'd say it's one of the conditions that can be moderately or modestly improved by the largest number of drugs. And I think this shows just how complex it is, in the sense that it's this complex behavioral pattern, and certain medications moderately help, but nothing seems to be highly effective yet. And that definitely points to the need for novel pharmacotherapy. And this brings us on to the topic of psilocybin, which is one really promising candidate.
I love that. And I wanted to put a point on something you brought up, is that some people take a pharmacologic medicine like an SSRI so that they can undergo the therapy. I think people a lot of times think either or, okay, I'm going to do the therapy or the medication, but like, we were discussing, the therapy itself may be very anxiety producing and they may be more anxious about doing the therapy. So the SSRI being on board may help them to even undergo the therapy. And so I'm really glad that you pointed that out, because I think we don't think enough about the role that one may play in helping with the other, instead of
Yeah,
just
yeah,
one or the other.
it's definitely easy to be reductionist and to think that a single medication could cure it, or that it's either or. But I think ideally, the future would look like better OCD therapy that's slightly more streamlined, and better pharmacotherapy to support that for the people that want it and need it, because it does end up being a very tenacious pattern for some people, where they feel like it's difficult to take those initial steps.
And so, since you brought up psilocybin, and that is the topic of our show, can you talk a little bit about why perhaps psilocybin was thought, whoever had maybe the first papers on this, why it was thought that psilocybin might be an effective treatment for OCD?
Yeah, sure. So I'm pretty sure your listeners are well acquainted with the use of psychedelics in the field of psychiatry. So I won't go too much into the kind of psychedelic renaissance, but there's been a lot of studies in the past decade or so, and some positive results for conditions like depression and PTSD particularly. But people do tend to overlook OCD, I feel, in the field, because I think people think of it as a very rigid pattern. And the thing is, vicious cycles can be interrupted at different points. So I think just because OCD becomes very rigid doesn't mean that something can't be paradigm shifting in treating it and the different symptoms. There was one study conducted in 2006, a pilot study into psilocybin for OCD. Researchers at the University of Arizona found positive results. They gave 9 participants 3 doses. I think they gave a total of 29 doses, so each participant had the doses, and then there was one extra dose, a couple of extra doses, but they were given a low dose, then a moderate, and then a high dose. And they found that all 3 doses elicited beneficial responses in symptoms, and they measured that as a drop in OCD symptoms by, I think it was 25% or over, and I think they had 25 to 100% decreases in symptoms as measured through the Y-box scale, which is the gold standard clinician-rated scale for OCD symptoms. And this is really, really interesting because there aren't any other medications that elicit that kind of relief so quickly in OCD besides benzos and other, anxiety reducing medications that obviously can't be used long term. So it's very interesting to see such positive results. And that study inspired our study, PsilOCD, which has come to a close now. We dosed our last patient and we closed the study in July of 2024. And we gave participants, I can say the dose now because we've finished the study now, but we gave them a 10 milligram dose of psilocybin, which is comparable to something in between the low and the medium dose employed in that pilot study held at the University of Arizona. And we opted for a lower dose because we didn't think people with OCD would want a very strong psychedelic experience. And we wanted to see if we could use a lower dose that would just have mild perceptual and emotional effects to kind of start maybe increasing cognitive flexibility in the brain, and to see if that would be feasible. And if that is feasible, we thought that would be something that would be tolerated by a lot more people than maybe this concept of a much higher psychedelic, a much stronger psychedelic experience.
I love that train of thought. That's so compassionate to those with OCD, because absolutely somebody who has, I would imagine, this rigid thought pattern, or like you said, these fears related to, and you added health in there, some health related fears, that if they take a high dose and maybe nausea kicks in, then they're nervous about the nausea, and it may sabotage the experience.
Yeah, exactly. I think a high dose could be great for some people, for sure. And there are studies at the moment looking into a higher 25 milligram dose, I believe. I think both Yale and Johns Hopkins are using that dose, potentially even higher, actually. And I think there is definitely, some argument for using a higher dose because it's also quite an entrenched pattern, and that might give some people an even more positive experience and get the therapeutic flywheel spinning even faster. But I think, like you said, I think in the main, I think it's best to err on the side of caution and just give people a positive experience and make it inclusive. So like you said, people who kind of maybe fixate on their health and on their even mental health and, sensations and things, they can benefit from, psilocybin without having to overcome that barrier.
Yes. And like we discussed earlier, this could be that one is the gateway for another. If they can do the low dose, see some benefit, and realize, oh, okay, I survived those lesser side effects, then maybe they will have more of the courage and the wherewithal to try that higher dose. So it may not be like, oh, we have to do one versus the other. It could be that at some point each has its role.
Yeah, that's also very true. There could be, gradual increases in doses. People might end up having, a couple of doses a year or maintenance doses alongside therapy, and there could definitely be different literal dosages offered.
And I was going to ask about University of Arizona, and I kind of assumed that the answer is no, but did they gather any long-term data? Do they know how long these effects lasted?
No, this study only looked at the 24 hours after dosing. So that's definitely important to point out, that, that it's definitely a limited follow-up period. But our study has a 4-week follow-up period for each participant after each dose. So we collected data 4 weeks after the 10 milligram dose. I don't think I mentioned that. Sorry, I think I got excited and just went straight to the real dose. But we also used a placebo dose. We gave them 1 milligram as an active placebo. And this let us employ quite good blinding because we could tell people that on both dosing days, like each participant's going to get up to 10 milligrams. So no one expected an actual inert placebo, and there wasn't one. And I think that's quite good to reduce the disappointment effect bias, and because it's quite a lot of effort, people would travel to London and things, and everyone was amazing on the study, but it could be quite disappointing to get into the dosing session and think this is a placebo day. So we told participants that they would get up to 10 milligrams, and the study was fixed order. Each participant had 1 milligram on the first dosing day, and then they had cognitive tests the next day. There was a lot of therapy. Symptoms were measured, EEG was performed, brain activity was collected on the day of each dosing session. And then 4 weeks after the placebo, they got the real active dose. So the whole span of the study was 10 weeks with those 2 dosing days.
And what kind of, I know this is a big discussion now with the FDA having said no to MDMA-assisted therapy for now. A lot of discussion goes into what kinds of facilitation or guidance or therapy or not therapy is going on in different studies. So what kind of therapy or not was taking place during those dosing sessions?
We didn't actually use any OCD specific therapy or techniques because our study was a feasibility study for psilocybin, just as a pharmacological agent. Does this drug on its own with supportive therapy, like just, non-interventional therapy, improve symptoms? But therapy was a very important part of the study. And Sarah Reed led it. I'm giving her a shout out because she's an amazing therapist. And she partnered up with a lot of other great volunteer therapists as well. And each participant was allocated 2 therapists, or guides, psychedelic guides, you could also call them. And they prepared the participants for the dosing sessions. They just spoke about general themes and explored their symptoms, but didn't really, promote any kind of exposure therapy or anything like that. And they also helped the participants integrate their experiences after each dosing session. And that was definitely a pivotal part of the study. And I definitely think that even though pharmacotherapy is really important and my background is, quite pure neuroscience and all of that molecular biology, I do think that the human element is really, really important. And I think participants having faith in the therapists and in the other people that run the study is a really crucial part, and that can almost be a self-fulfilling prophecy too. So yeah, therapy was a really important part of the study, but we didn't employ any kind of OCD specific interventions. And I think doing that could definitely be a lot more effective. I think in the future, we can speak a bit more in depth about this maybe, but in the future, I think ideally people would be, like I said before, they would be engaging in some kind of exposure therapy around their specific fears, because I think it's difficult for people to overcome OCD without facing their specific topics, because it is, it's an avoidance driven pattern. And I think unless they desensitize to what they fear in some way or another, I don't know if they could actually exit the cycle, but they could do so supported by maybe occasional low to moderate or even higher doses of psilocybin.
And I'm going to back up 1 second and ask, so during the sessions in your study, were those therapists just, like you said, supportive therapy, they're just in the room, just to make sure that nothing bad happens? And if they happen to want to talk, then it's kind of like the non-directive therapy that we see in a lot of the other studies?
Yeah, exactly. That's how the model was. So the participants would recline in the bed and they'd have one therapist on either side. The room would be very dimly lit, quite Scandinavian chic, a really nice setting, with some plants and things in the corners. And yeah, if anything came up and the participant wanted to discuss something, the therapist would be there, but they wouldn't really, they wouldn't be prompting conversation. And there'd also be music all the time, and the participants would be instructed to, well, not instructed, they'd be, they'd ideally listen to the music. Occasionally they'd want to take their headphones off, and that was fine, but the goal was to just get them to recline and to almost have an inward experience, not be engaging too much with the external world.
Yeah, absolutely. And then when you discussed that there may be a role for directed specific OCD therapies plus psilocybin, were you thinking about those therapies taking place during the journey or perhaps during the critical learning period that we know is open after something like psilocybin?
I think doing them during the experience could be really interesting. I think it could benefit some people, especially if their OCD centers around maybe trusting their own capabilities, trusting others, I think that could be a great way of benefiting from that acute state. But I think it could also be quite ambitious, especially because of the emotions that can come up. So I think benefiting from that enhanced neuroplasticity might be more realistic. And maybe, doing a session the next day, doing, an ERP type session. I think that's something that would be more likely, with maybe some kind of integration as well, separate to the ERP.
And as I'm thinking beyond, so oh, by the way, sorry to all the listeners who are like, what are the results? The results have not been released yet. Sorry, this is like a teaser episode. I just had to do it. We will do a second episode where Sorcha will come on and she will tell us the results. I'm sorry to keep you on the edge of your seat. You're like, what if what if that you are, we're talking about anxiety and then now you're giving us something we have to wait. I'm so sorry.
They should be in the next couple of months. So hopefully I'll be able to come on an update soon. It's very tempting for me to reveal them, but I think
we can't do it.
Happy.
Yes, we have to respect the academic process. But what we like to do a lot of times on the show, we do bring up concepts, right? Because if you're a listener out there and you are struggling with one condition or another, we like to provide hope, So maybe we don't have all the answers, but okay, if you are a person struggling with OCD, here's perhaps hope that this, the study results will be positive and you might start thinking in that direction. Or, if you are a person in Oregon or now Colorado, or let's say soon Colorado has legal psilocybin now, but no service centers are up and running. This is recorded in January of 2025. But then you do have legal psilocybin at your disposal if you have no other medical contraindications. Always asterisk, please see your primary care physician first. But that's why we sometimes bring on things that do not have, most of psychedelics do not have definitive answers at this point, but we like to start bringing on possibilities. And so we will bring you an episode with the results. But I started thinking about, since there's been the study done in 2006 and your study, and you said that there are some other studies taking place in the States with psilocybin and OCD. Is there a thought that other psychedelics, maybe my question is kind of twofold. One, the other serotonergic psychedelics, and then two, maybe something like ketamine. Have there been thoughts that either of those classes might also be effective for OCD?
Yeah, there are a couple of case studies looking into LSD, and people, anecdotes, people do experience benefits from microdosing and also from higher doses. But I think the focus seems to mainly be on psilocybin, and I think it's because maybe it's a psychological element as well, that it just seems a bit more kind of earthy, and maybe people feel like it's, more intuitive to use it for a study. But I think there are also other slight benefits. I guess it's slightly less energizing than LSD, even at a lower dose. But in terms of ketamine, there are mixed results. And I feel like, ketamine obviously acts, as a glutamatergic antagonist. And that's definitely an element of OCD that is, abnormal. There's abnormal glutamatergic transmission. But I don't know, personally, I'm not so sure how effective a treatment it could be for OCD. I don't know if it would be as effective as it is for depression. But that's definitely something that I think could be beneficial for some people if they're okay with the dissociation element of it as well, because it's a different kind of experience. But yeah, in terms of shorter acting psychedelics like DMT and others, I personally think I feel like they might be too intense for the condition. That's my own view. I don't know if I were a clinician, if I would want to use them, but it'll be interesting to see, especially with the pharma companies coming out with these, short, analogs of DMT and 5-MeO, to see if they end up exploring them in the context of OCD.
Yes, absolutely. So before we wrap up our first intro/teaser episode for this, are there any other things that I haven't asked that you'd like to share?
I don't think so. You've asked great questions. I'm trying to think if there's anything the listeners might be interested in hearing besides the results coming out imminently, hopefully.
And by the way, I'm going to step in here and say she just gave me credit for great questions that she wrote, because she is this good. Usually I just like free flow, and she was like, here is some like a great flow. So Sorcha, you're just like such a fantastic guest.
You did freestyle a bit though. You freestyled very well.
Freestyle. I love it.
I guess if I just to close it, I think one thing I realized is this whole kind of discussion can sound very clinical and like it's very rooted in the biomedical model of OCD. And I think that's probably the easiest way for this research to be done. And I think it makes sense in this kind of society, and that's how we talk about these conditions. But I think it's important, especially if any listeners have OCD, to realize that these cognitive features, all of this talk, it can sound very serious, and it can sound like, oh, OCD involves, these entrenched, intractable cognitive features, and it might sound limiting to someone who feels like they're improving. And I guess I'd just like to stress that this is academic talk, and that this, if not everyone with OCD has these cognitive features, to call them that, and it's not necessary to fixate on that too much. It's just the way that research is swinging at the moment, and people are interested in looking at the underpinnings of the condition. But ultimately, if you studied any kind of phenotype, whether pathological or not, you'd find certain features and people would write about those. So I guess I just didn't want to, introduce people to, if they're hearing about this element of OCD for the first time, to make it sound like it's something that complicates recovery even more, because I know that can be a strong sentiment in people with OCD. I think that's something important.
Well, I appreciate you bringing that up. And also, I appreciate you having discussed how it's now more of a range of conditions. And OCD doesn't look like just like one thing. I think we've seen a lot of maybe kind of characterization or almost like comicalization on television shows with, I think of The Big Bang Theory with Sheldon and his three, like if anybody's seen that show, he has to like knock 3 times and all of these things. And
Exactly.
I think it looks like many other things. And that's part of what you were trying to illustrate, is that there's a wide range of ways it can look. And so not to overfixate on, oh, I do or do not have this specific characteristic. So my OCD is or isn't getting better, or even is or isn't OCD. And by the way, maybe this will be like the last question I'll ask. If somebody thinks they might have an obsessive compulsive related disorder, what is the best way to get a definitive diagnosis?
I mean, I guess if you're in the UK, the best way is to initially go to a GP. And do you mean that process, or you mean
Oh,
in
yes.
general?
Well, I guess a psychiatrist is that who generally would do that?
Yeah, exactly. A psychiatrist would give you the diagnosis in the UK, and then you can engage in therapy and also look into medication if you're interested in that. And a psychiatrist will typically offer that, often both. But besides that, a lot of people look into psychotherapy as well. They'll find a psychotherapist who isn't a clinical psychologist or a psychiatrist, and get maybe some additional therapy. I guess I'm giving maybe a slightly vague answer, but yeah, I think a big thing as well that people can miss is the mental side of OCD, and I think sometimes people don't realize that their mental rituals are actually OCD. That's something that I've definitely realized, especially, having our study inbox and a lot of people getting in touch. I think a lot of the time people think that their excessive ruminating is logical or reasonable, the best thing to do. And it definitely sits on a spectrum of behaviors that can be adaptive. It can be helpful to overthink, but I think a lot of the time people overlook these mental compulsions. And there's a psychologist that's who's really good, called Dr. Michael Greenberg, and he writes online and he talks about rumination and how to spot it. And I think that's something that I forward to people who have those kinds of challenges.
Thank you so much. We will link to him in the show notes. I guess my question was just, is there a test? Is there like because you had talked about the scale that is used to evaluate
technique? Yeah.
Yes.
So people use the white box scale and just YBOCS to diagnose OCD. So if you go to a psychiatrist, that will be how they assess it. And it's split into different facets. They have different scales to look into obsessions and compulsions. And it's become more advanced now. It's been revised several times. And then, it's now pretty good at, if the clinician is aware of these types of more subtle compulsions that can be mental, or, someone Googling things, not necessarily the hand washing or the, tapping things. If the clinician is aware of these more subtle compulsions and the patient is aware of the fact that, they are exhibiting them, it's pretty good at picking up OCD symptom severity. And that's
Got
also
it.
the stuff that we used in our study. and we measured symptoms at 7 different time points over the course of the study.
Okay, thank you for that clarification, and thank you so much for coming on and sharing with us. I cannot wait until the follow-up episode where we get to hear the results.
Thanks so much for having me. It's been great, and I look forward to coming back on.
Ah, fantastic. Well, for everybody else out there, until next time.